All right, so it's 4:05 and we've got a very action-packed hour for you at today's SimCity rounds. It's our first rounds of 2023, and I'm really excited to start it off with a team of psychiatry residents and a psychiatrist. This team works very closely with our Sim Center at CAMH, and I'm going to hand over to Dr. Michael Mack, who is supervising Dr. Zhu, Dr. Solomon, Dr. D'Souza, and Dr. Samuels. I've pasted their bios in the chat because if I were going to read all the amazing accomplishments of this group, I would take up the entire SimCity round. So Dr. Mack is going to introduce them and then get things rolling, and I'll get involved for the moderating of the question and answer period. Welcome, everyone.
So everyone can see the screen now. So thank you so much for the introduction, Dr. Abdul. Today, we'll be talking about simulation as it pertains to psychiatry and the fantastic involvement of psychiatric residents in developing simulation-based education for our program. So Psych for Sim, an update of simulation innovation by psychiatry residents. Thank you for coming. This is an overview of what we're going to discuss today. The first talk will be held by Dr. Hannah Solomon, who will give us the State of the Union about simulation and its place in psychiatric training. Subsequently, Dr. Hannah Samuels will discuss with us her experience in creating a code white video simulation that is used in medical education. We've used this in the training for medical residents, but also healthcare workers in general. Subsequently, I will discuss EPA and trustability by simulation, the experience that we've had in the psychiatry program, using simulation as a means to assess for EPA and trustability. We'll finish off with doctors Finola D'Souza and Yunlin Zhu, and they'll talk about their experience in developing and writing and creating a simulation-based training program for our residency program, focusing on code blue and code white presentations. And with that, I will turn it to Dr. Solomon.
Okay, I'm just gonna share my screen. Okay. Hi, everyone. My name's Hannah Solomon. I'm a third-year psychiatry resident at U of T. Today, I'll be talking about resident perspectives on the use of simulation in psychiatry training. I just want to firstly thank Amy Graham. She's a second-year medical student at U of T, and she's been very helpful in the development of this project. And then I also want to thank my supervisors, Dr. Mack and Dr. Sokolingam, for all of their supervision. So let's get started. So firstly, objectives. We'll review the current literature regarding the role for the use of simulation in psychiatry training. Then we'll review the development of a survey to assess resident perspectives on the use of simulation in psychiatry residency training. We'll review the current U of T psychiatry resident responses to the developed survey, and then discuss next steps in survey expansion. The primary objective of the literature review was to review the current literature regarding the use of clinical simulation for education in undergrad and postgrad psychiatry education. So the rationale for this literature review, I'll just take a few minutes to talk about it. So as I'm sure all of you are aware, simulation has been proven to be an essential educational tool, allowing learners to develop their clinical skills in a supervised and safe environment. In surgery, it's been quite well demonstrated and documented in many studies that learners practicing on a simulator leads to improvement in performance on real patients in the operating room. In psychiatry, OSCEs, so objective structured clinical examinations, have been used for residents and medical students alike for a long time, but simulation for education and training purposes has been used much less frequently. So as noted in the McGill review paper, only 20% of medical schools and 5% of teaching hospitals use simulation in psychiatry residency curriculum as compared to the mainstream use in surgical residency training programs. So we did conduct a literature review, and we were very fortunate to have Sarah Bonato, a CAMH librarian, help us with this. So we did the search on two search engines, PubMed and PsycInfo, using the search terms simulation and psychiatry and education. The search was initially limited to reviews and systematic reviews, and then was seeing the most recent systematic review being conducted in 2021. We also looked at primary articles after that time. The exclusion criteria were as follows. We excluded papers that focused on allied health professionals, such as nursing students, and didn't focus on medical students or residents. And then we also excluded papers that were focused only on simulation as a form of assessment and not learning or education. And in total, we reviewed 17 papers. I'll talk about the findings in the review. So the first part of the review focused on the different types of simulation, and the McGill paper kind of categorized it into 6 different categories. I'll just run through them. So for low technology simulations, which is using a very basic mannequin to learn basic skills, then standardized patients are actors who are simulating real clinical scenarios. Screen-based computer simulators are 2D computer software that can be used to teach clinical decision-making. Complex task trainers are not really used in psychiatry, but they're more for learning high-level procedural skills. High-fidelity simulators are computerized-based mannequins, and these definitely have a role in psychiatry for teaching neurostimulation. And then virtual reality, which is kind of the newest avenue in terms of modality for simulation, is 3D, a 3D experience using different sensory inputs to simulate a clinical scenario. So I'll just go back. In terms of the most common type of simulation modality used in psychiatry, that would be human simulation, so standardized patients and role play. There definitely is a utility for using high fidelity simulators such as mannequins, and then virtual reality as well. In terms of the types of scenarios that were most commonly found to be used in psychiatry simulations, those are emergency scenarios such as patients with suicidal ideation, self-harm, violence, procedures, mainly neurostimulation, ECT, RTMS, and then psychiatric medical emergencies such as NMS, serotonin syndrome, or intoxication and withdrawal syndromes. The PO review did highlight that there were certain areas in psychiatry underrepresented in simulation, and those were psychosis, mania, personality disorders, child and geriatric cases, and neurodevelopmental disorders. In terms of effectiveness, the meta-analysis by PO did illustrate that despite a great deal of heterogeneity in the different simulation methods and techniques, simulation did cause change in behavioral and skill-based outcomes. So that study looked at it at like immediately post-simulation and then 3 months post-simulation. There isn't as much evidence that we found about like the long-term effects of simulation's effect on trainees' behaviors. In addition, there also is quite limited evidence looking at the effects of simulation on patient outcomes in psychiatry, especially compared to the in the surgical specialties. It would be, I mean, one can imagine it's a lot harder to measure mental health outcomes compared to some of the outcomes they'd be looking at in surgery. So after doing this review, it really got me thinking, well, what do residents think about simulation being used in their training? We did a search on a few different search engines with the help of our librarian and identified a gap that there are no papers or studies that look at resident beliefs and perspectives on the use of simulation in their training. And I think this is an important gap to fill because the trainees' perspectives and beliefs about simulation most definitely will affect their engagement in it. So we did create a survey, and it was informed by the literature review and then also by different medical education survey development papers, such as the Artino paper. The survey was sent out via email to all of the psychiatry residents at U of T. Their responses were anonymous. We looked at 5 different areas in the survey. So the timing of simulation, the benefits of simulation, the barriers to engaging in simulation in psychiatry, CanMed's roles and how those would be relatable to simulation, and then looking at the EPAs, so the entrustable professional activities. So most of the responses were rated on a 5-point scale. There was also a section in the survey where residents could check off more than one response. And we did have some free text questions for residents to respond to as well. The results are here. We had in total 25 respondents to our survey, which I'll discuss later. It was much less than we had hoped for or expected, despite sending out multiple emails to the resident body. In terms of the responses that we do have, you can see there is a spread, a pretty equal spread among PGY1s to PGY4 residents. We felt it would be useful to know in the past, what experience did residents have with simulation? As you can see, in terms of psychiatry simulation specifically, 44% of residents had experience in medical school and only 28% had experience in their residency training. So the first area that we looked at was timing. How willing would residents be to engage in simulation based on different time parameters? It was more clear that residents would be more likely to attend if it was mandatory, so built into the curriculum, versus if it was voluntary and they kind of had to accommodate that into their own schedule. Residents were agreeable to attending if it was virtual and perhaps a little bit less in person. The next category is the EPAs. So all the residency programs in Canada now are competency by design programs. So residents have to get a certain amount of observed entrustabilities in many different areas in the specialty. So we were wondering if residents felt that some of these EPAs could be met via simulation. The top 4 EPAs, which residents felt would be amendable to simulation, were performing risk assessments that inform the development of an acute safety plan, obtaining a psychiatric history, psychiatric assessments related to geriatric patients, and then dealing with emergency situations in psychiatry. I will note that neurostimulation was the 5th response, the top 5th, which was actually surprising to me because in the free text responses, it came up so commonly that neurostimulation would be a big help with simulation. In terms of the EPAs for which simulation would be of least benefit, number 1 was managing the clinical and administrative aspects of a psychiatric practice, developing and implementing personalized training experiences geared toward career plan or future practice, and then performing critical appraisal. So we also looked at the CanMed's roles and what residents thought about simulation being used to gain more comfort in these roles. What was clear is that residents were the least confident that it would be helpful for the health advocate role. They did show some confidence towards it being helpful for the communicator role and the collaborator role. In terms of different skills that residents felt simulation would help for, they did identify that simulation would be helpful for rare encounters and having access to a wide variety of clinical scenarios, in addition to getting feedback about academic competencies. They did identify that they felt simulation would be the least helpful for empathy, which I'll talk about in relation to the free text responses. For barriers to engaging in simulation, the #1 barrier noted was time. And being a resident in our psychiatry program, I can recognize that we have a very busy schedule. And unless there would be some sort of protected time or it was integrated into our schedule, I think it would be hard to get residents to attend. So that can go into, when a curriculum is developed, that should be taken into account. Residents also noted that resources were a barrier, which has been brought up in multiple reviews from the literature search. And then they also said fear of embarrassment and fear of being judged by your colleagues. My personal take on this is, being a resident in the program, we don't do a lot of assessments in front of our peers. I think that may be like anxiety provoking. I think if residents did more simulation, they would perhaps be more comfortable doing assessments in front of their peers, and that would go down. For the free text responses, we had a wide variety of opinions. So there was some skepticism among the resident body about the utility of simulation in psychiatry. I think it would have been interesting to know what these people's experience with simulation has been so far, because that in itself is variable. In terms of like areas that residents felt would be helpful for, as we spoke about previously already, so neurostimulation, emergency situations, medical emergencies. Sorry, I already said that. Neurostimulation, medical emergencies, rare situations. They felt it would be a good way to get feedback. In terms of areas where simulation would not be useful, these two categories were identified by residents. For psychotherapy, in the literature, there is kind of like a mixed opinion about using simulation for psychotherapy. In the Brenner review, what Brenner brings up is that while it may not be helpful for simulating like a psychodynamic therapy session, it could be helpful for simulating and teaching residents specific skills. And I can already think about skills like in my own practice as a resident doing therapy that it could be helpful for example, dealing with therapeutic alliance ruptures, setting boundaries, dealing with boundary violations, redirecting patient, common scenarios that residents will deal with in multiple different types of therapy modalities. And for empathy, again, the literature on it kind of brings up mixed thoughts about empathy being able to teach empathy via simulation. I did read an interesting perspective that felt that virtual reality, so allowing a resident to experience what it is like to have psychosis, and we can even extrapolate this to like, a substance use disorder, may allow residents to have more empathy for some of these like more stigmatized diagnoses. For the low response rate, basically, we sent out an email multiple times, didn't get more responses. We plan to disseminate the survey to all residents in psychiatry programs in Canada in order to get more robust data. And we're doing this via COPE. We also hope to actually develop a similar survey to send out to psychiatry program directors to see their perspectives. I would say that the free text responses were very interesting and fruitful. So I would be interested also in perhaps doing some focus groups or semi-structured interviews to get like more data in that way. So that's my presentation. Thanks so much for listening. I'll unshare my screen. Can I do that? How do let me just, or maybe the next person should just share. I don't know. How do I unshare it?
I think, there we go.
Oh, did I unshare it?
Yeah, now.
Okay, great.
Perfect. Now I can share my screen here. Okay, and then play from current slide. Okay, can everyone see that? Okay, So my name's Hannah Samuels, and I'm going to give a quick presentation today on a video that we developed to be used in conjunction with the simulation that Hannah Solomon was speaking about. So the title of the quick presentation is Creation of a Code White Video Simulation in Psychiatric Medical Education. And a huge thanks to Kate Van de Burr, Fabienne Hargreaves, Stephanie Sleekers, Rachel Antonucci, Aylin Torfison, and of course, Dr. Mack for helping with this, with the creation of this video. So let me explain a little bit more about it. Oops, there we go. Okay, so the purpose of the creation of this video was to use visual media to complement simulations in medical education. And what we really wanted to do was to provide almost like a training video or to role model an example of how to deal with an agitated patient in a code white scenario that could be administered asynchronously to healthcare workers, residents, and medical students. So what we mean by asynchronously is that people could choose to watch it either before engaging in a simulation or at any time that they choose if they feel like they want to brush up on how to deal with a code white situation. Okay. So it would probably be important to explain what a code white is. A code white is initiated in order to obtain immediate assistance from clinical staff and security due to a psychiatric emergency involving a person's imminent risk of harm to themselves or others. And code whites have a high risk of physical and psychological trauma to both patients involved and the healthcare team involved. You can imagine that this can be quite anxiety provoking, especially for young learners. And so having a model of how to deal with this appropriately, we thought would be important. Education interventions must be developed for proper training so that not only can people feel more confident, but also that to ensure that they're safe. And these skills are better learned through experiential learning, including virtual simulation and not textbook learning. So like I said before, the project that we did aimed to create a code white video simulation to be used in conjunction with an in-person code white simulation to model appropriate management of an acutely agitated patient. So how did we do it? Basically, we developed a code white scenario script based on my own personal experience working in the CAMH emergency department and dealing with code whites. And then we obtained feedback from the TIDES team at CAMH. That's the trauma-informed de-escalation team they explained like what language we should really be using in modeling. And then we also obtained feedback from people with lived experience who contributed to the script as well. And then we had multiple meetings and iterations. We finally created the final copy of the script. And then we worked with the CAMH Simulation Center to actually recruit staff and hire a simulated patient. And then we filmed the acting of the script. So you can see the actual video is not included in this presentation, but I just put pictures from the filming process here on the right-hand side of the screen. You can see we had like a pretend nursing station. Here's our agitated patient. And you can see even just like how the team is standing and the words that they use modeled to anyone who's watching how to appropriately manage an agitated patient. So this video was then distributed in training sessions to residents and other healthcare workers, and we did request feedback from people who watched the video, and based on the feedback survey data from student evaluation, 48% of students rated the Code White video as moderately useful for their learning, and 24% rated it as greatly useful for their learning. We believe that a limitation of this is that surveys are anonymized, so we don't know which learners of which PGY levels responded to the survey. And it may be that this video is kind of more useful to residents who aren't used to dealing with code white. So maybe residents in earlier years of training as opposed to later years of training. So we require further detailed evaluation to understand the impact of this video on learning and confidence in dealing with code white situations. These are some of the references that we used, and this is just, you'll hear about the actual simulations coming up, and this is just a video that can be used asynchronously in combination with that. I will unshare.
Thank you, Hannah. So for this next section, I'll be talking about EPA and trustability through simulation. It's our experience in the psychiatry program at our Sim Center here at the Center for Addiction and Mental Health, and we've done so under the direction of Dr. Petal Abdul. So this diagram we're all very familiar with. Residency training programs in Canada have transitioned to a competency by design model, a training style with which we're all familiar at this point. Residents are evaluated for progression from the point of entry to residency all the way through to independent practice via entrustable professional activities, which are medical skills and tasks that an independent practitioner would do on a regular basis. So here we have the 20 full EPAs that we have in the training program for psychiatry, ranging from the transition to discipline all the way to transition to practice, which represents the end of one's psychiatry residency training. And you'll see that at the beginning stages, you're learning sort of, the fundamentals of psychiatric practice, learning how to take a history, communicating clinical encounters and documentation, so on and so forth, until the end of your training, when you're really learning about how to lead a team and running your own clinical service. So of the 20 Royal College EPAs in psychiatry, there are 6 that have already been pre-identified by the Royal College as EPAs that are suitable for entrustability in the simulation setting, and they make sense to us. So here they are on your screen. We have performing psychiatric assessments, developing and implementing management plans, developing formulations for patients so that we can gain an understanding of a patient, how they got to be where they're at and how they developed their psychological symptoms. Moreover, identifying, assessing, and managing emergencies in the psychiatric context across the lifespan, learning the skills and application of neurostimulation, as an example, ECT and RTMS, and then lastly, applying relevant legislation and legal principles. As you know, the practice of psychiatry is intimately related to the law because of the Mental Health Act, so on and so forth. So simulation and EPAs in psychiatry, while the use of simulation training is nascent in psychiatry as compared to other disciplines of medicine, we know that simulation-based training facilitates a controlled, safe, and reproducible assessment environment. This allows us to forego using patients as a training resource, and this has implications for standardization of assessment, as not all training sites will have the same level of acuity of patients. So as an example, if we're teaching students how to manage psychiatric emergencies, this is a way of ensuring a standardized training assessment baseline. Moreover, training resources vary across hospital sites. We have a large program for the psychiatry training program across all 5 PGY years. There's 150 residents, and to organize them to access an ECT or RTMS suite would be a challenge of access. And certainly we saw that in our program. This was certainly made worse by the COVID pandemic. So we've identified the EPA for neurostimulation as something that was lacking in access. And we foresee that simulation will be a means to bridge this gap. So simulation also allows residents to practice high stakes training without endangering patients. While EPA assessments should ideally occur in clinical settings, workplace-based assessments of some EPAs is not feasible, and sometimes it's not safe or ethical. Here on the screen is the core EPA for identifying, assessing, and managing emergent situations in psychiatric care across the lifespan. As you can see, simulation is a suitable setting to achieve entrustability in this particular EPA. And you'll see here that they've listed some presentations that would constitute an emergent situation in psychiatric care. So you'll see on that list, serotonin syndrome and neuroleptic malignant syndrome. These are on that list of emergencies to be assessed and managed, and for our trainees to learn. We believe that it is safer to train residents via simulation to address these medical emergencies so that they have some in vivo experiences above and beyond simple didactic teaching. Without simulation, the training that residents receive as it relates to managing these types of emergencies is on the job. So I think that this simulation allows us to train our residents in a safe and ethical environment. As such, we are building capacity in simulation-based training in acute care psychiatry, and with that, EPA entrustability. Doctors Yunlin Zhu and Finola D'Souza have created a code blue and white simulation training program for psychiatry residents, and those who have completed our pilot have been assessed for EPA entrustability. The data that we have produced as it pertains to learner satisfaction and confidence in code blue and code white management have been very positive and substantial. The learners thought that EPA entrustability assessment from simulation training was fun, efficient, and engaging, and preferable to simple didactic teaching. So during the development of our code blue and code white scenario, we identified EPAs that did not have prior approval for entrustability in the simulation setting, but otherwise seemed amenable to this modality. And the one that we identified is FOD1 before you, assessing, diagnosing, and participating in the management of patients with medical presentations relevant to psychiatry. And what we did was we reached out to Dr. Kim St. John, who was the chair of the specialty committee in psychiatry at the Royal College. She and the Royal College committee demonstrated a willingness to discuss this, and we are happy to say that they actually approved an expansion of EPA entrustability settings to include simulation for this specific EPA. And furthermore, we have reached out to them to see if they are willing to expand and include the FOD4 performing risk assessments that inform the development of an acute safety plan for patients posing risk of for harm to self or others, and expand that setting for entrustability to include simulation. And thank you to Dr. Hannah Samuels for taking the lead on that. So what about next steps? What's the future? In a needs assessment that we performed 2.5 years ago, outside of the code blue and code white scenarios, the following scenarios are the ones that were identified as topics that residents found possibly useful. We have suicide risk assessment. We know that Dr. Abdul is already investigating the merits of suicide risk assessment by virtual means versus desktop means. We foresee that this will eventually lead to EPA entrustability assessments for residents, withdrawal syndrome, and as well as consent capacity board hearing training, leading to entrustability in the CO9 legal EPA. These appear to be next steps in our future roadmap. And with that, I will turn the presentation to Drs. Yunlin Zhu and Finola D'Souza.
Thanks, Michael. All right. And thanks to everyone else for their amazing presentation. So Yunlin and I will be talking primarily about our pilot project on developing and implementing simulation, particularly for training in emergency situations. So hopefully by the end of this talk, you'll learn about how we can use simulation for psychiatric education. I won't belabor this point because the other doctors have already done a great job talking about it. And we'll also be exploring about how simulation can increase competence in responding to psychiatric emergencies, using and talking about our pilot project. And then lastly, we'll be going into some details about how you can actually develop a simulation so that they can focus on the EPAs that Michael was just describing. We've talked about the benefits of simulation. Just want to highlight that it is a type of training that's particularly effective for adult learners, because we know that adult learners really benefit when they understand the implications and the clinical outcomes of what they're learning. We know that simulations are, they're immersive, they're safe, particularly when looking at emergency situations, and that they can look at real life, again, emergency situations, but be a substitute way of learning without the clinical consequences. And when we're looking at learning in particular, a lot of the education comes from the observation and the debrief stage of simulations. Simulations also have multiple modalities. They can look at everything from education, evaluation, all the way to quality improvement. For our project, we really wanted to focus on the education aspect of it. And we've talked about this paper before. Again, I just want to highlight that in the past, simulation was really was involved in more of the emergency medical training as well as surgical medical training, and not a lot of it was within the psychiatric realm. But there are studies pointing out that there is use and benefit for it within psychiatry. And this was particularly relevant for this pilot project that we did together, which was looking at how can we implement simulation, particularly at CAMH and at U of T. So why CAMH and why U of T as a pilot program? The U of T residency program is one of the largest residency programs in North America for psychiatry in particular. And because of that, we end up having a very multi-site residency program, which means that a lot of our training for code whites and code blues end up being on-the-job training. And that often leads to a lack of standardization. Additionally, the unique aspect of CAMH, with it being a tertiary psychiatry site, we don't have a lot of the other medical specialties that tend to respond to medical emergencies. Like we don't have a standardized code blue team, for example. As a result, that means that psychiatry residents are the first responders to a lot of code whites as well as medical emergencies that you tend to see at CAMH. And oftentimes these aren't something, again, that psych residents are formally trained in. It just so happens that we see it on the job, and then that's the way that we end up getting most of our clinical training. And then because we know that simulation is an effective tool for training within high-risk situations, we identified that there was a gap that could be filled in psychiatry education by using simulation. So the goal of our project was to improve and standardize training for psych residents at U of T, in particularly looking at different aspects of code whites and code blues, and hopefully with the goal to get it more standardized across the different hospital sites. So we as well conducted a needs-based assessment, and we sent out a survey. We ended up getting 27 responses from PGY 1s through 6s. The primary takeaway from this is that majority of the residents said that they're not confident in leading a code blue at CAMH, and that 50% stated that they weren't even aware of what their role was when responding to a medical emergency. All of the respondents said that they were interested in more training and responding to psychiatric emergencies, and these included things like seizures, overdoses, as Michael mentioned, things like NMS. And then they wanted more simulation training, both in responding to medical emergencies as well as aggressive patients in code whites. So with this information in mind, we decided to develop a simulation team, and our team included a couple simulation educators who really were the ones who disseminated their knowledge and trained Dylan and myself. We had psychiatry staff. Our current simulation team is expanding. In the beginning, it was the two of us. And then the important part that I want to talk about is members of lived experience. So in psychiatry, we tend to have a lot more intense patient interactions and more time spent with in conversation with our patients. And this means that they really are able to bring in a breadth of knowledge about the validity of our simulation scenarios. Are we really being trauma-informed, patient-centered, culturally aware? And having their input in developing the simulations was crucial, ensuring that that our simulation scenarios were effective. And then we were trained on, again, how to develop a simulation scenario, looking at articles, case development, and then didactic teaching. And from there, we identified two situations we really wanted to focus on. For the pilot, Yulun will talk about the code white as well as the code blue seizures. And then through there, we identified different checklists and how were we able to lead the pre and debrief during the simulation. So I'll turn it over to Yellen now.
Great, thank you, Vanilla. I'm just gonna request to control your screen. Okay, thank you. All right, so the three main elements of a simulation is the pre-briefing, simulation scenario itself, and lastly, the debriefing. So the purpose of the pre-brief is really to sort of set a framework, introduce everyone, orient them to the simulation environment, set some expectations for learning. Also just setting a psychologically safe space, saying that this is a place where you learn. We want to keep everything confidential. And lastly, we are doing some didactic teaching ahead of time for the scenario. The pre-readings are given to the students beforehand, and it sort of just gives them a theoretical groundwork to work upon while they do the simulation. So this is an example for the Code Blue pre-readings. Then the scenario itself, I will walk through our Code White and Code Blue to show everyone what it kind of looks like from a developmental perspective. So when we make the Code White, we come up with learning objectives here. Also, we have to list out our general logistics. So for example, the Code White scenario itself, we have to specify that it's 25 minutes. It has 5 parts. We get each resident to do one of the parts. And between the different parts, we actually have debrief sessions. Then we also have to come up with, we have to write up scenarios. Something like this. This doesn't get, this isn't given to the students, but it's actually given to the facilitators and the standardized patient to teach them what to say, how to say it, when to escalate. And this also includes a whole checklist for the facilitators to go through what to look for when the students go through the scenario. Taking a while for the slides to move. Okay. Okay, and then for the Code Blue, some specific things are, we do have a mannequin that has blood pressure measurements, injection sites. We have a crash cart that we orient the students to, and we have a vitals machine, as well as a lot of different equipment such as glucometers that they can use to test values on the dummy and on the mannequin. And also if let's say if the scenario doesn't go a certain way, we have to plan for alternatives. So for example, if the team is unable to control the seizure within a certain amount of time, we do change up the scenario, so the vitals will change and they have to adapt to that. And finally, the debriefing is the most important and sort of the best place for learning from our perspective. Is we go through a framework for debriefing. We describe the situation that happened and have people give feedback on how they felt, what are some reactions, what are things that are shocking, what they liked, and we really go into the analysis. And for the Code White scenario, we have a really valuable tool. We actually bring in our standardized patient to give feedback to the students about what you said during the scenario. This worked, this didn't work. You could have said this in this way. And right now we're actually doing a second run through, so the residents can actually practice all the skills that they've learned through the debrief process. And as Dr. Mack was saying, we use simulation as a bridge to help residents gain entrustable professional activity. So just as a reminder, these are assessments that are part of the competency by design curriculum, and each resident must have at least 3 entrustable EPAs in each category to complete their residency. For our Code White, students are able to complete the COD5, which is identifying, assessing, and managing emergent situations in psychiatric care across the lifespan. And then for the Code Blue, residents can actually complete 2 EPAs. So the first one is FOD1, assessing, diagnosing, and participating in the management of patients with medical presentations relevant to psychiatry, and COD5, which is the same as the Code White. And these are quite helpful for us because even just from personal experience, we don't experience a lot of these situations as often as we would like. And we feel we don't get enough training or comfort to deal with these situations when they do arise. So the simulation really helps with that degree of comfort. And just to go through our pilot, we ran 2 pilot simulation days. In total, we had 9 participants. This took 2 half days. With the Code White, we had a simulated patient. And we evaluated them using pre and post studies, post surveys. So this is what the pre and post surveys would look like. This is just an example of some of the questions. We used a 5-point Likert scale, and we assessed them on their knowledge and confidence of these different elements. We actually also included elements of the EPA itself, like the breakdown of the EPAs, and asked about their confidence in each of these elements before and after the simulation. And just results wise, from the Code White scenario, all the participants saw a 19% increase in knowledge on the Code White learning objectives, and similarly 19% increase in the Code Blue knowledge. From a confidence level, with regards to the Code White EPA, the participants saw a 20.44% increase in their confidence on the different elements of the EPA. And for the Code Blue, in the first EPA, the participants saw a 10.4% increase, and the second EPA saw a 16.2% increase. All this is to say that the participants have found this to be quite helpful in gaining confidence in completing their EPAs. And these are just some quotes that residents have added to sort of describe their experience. They thought it was engaging in real time and not just going through the motions. It's hands-on practice that are not commonly used as psychiatric residents. It's engaging, it's easy to remember, and they like the repetition during the debrief. They also found the debrief experience to be quite helpful to discuss in a group, analyze each other's feedbacks and perspectives. They found that debrief is an underutilized tool to reflect and learn. So they really appreciate the opportunity, and it helped them gain more awareness and not feel as alone in the situation. We did have a very exciting development this year. We applied for the COPE Special Education Fund, which is a national initiative for postgraduate education, and they award $2,500 to 3 groups nationally for resident-led initiatives, and we were able to obtain this funding. So the next steps for us are to expand the scenarios for simulation. We're looking into things like brain stimulation teaching, developing and implementing a simulation for psychiatric education at a program level. So for example, embedding it into the first year teaching called Ground School, which is a month of teaching done at the beginning of psychiatric residency, and also expanding this teaching to different hospital sites. We're hoping to apply for more grants and also use mastery-based values in sim pre and post debrief. Okay, thank you. If anyone has any questions.
Thank you so much. It was a very action-packed rounds, but I think every piece every piece that followed complemented what was covered. Do we have any questions? Let's open it up for questions in the last 6 minutes.
I really liked, it's more of a comment, but I really liked how you guys looked into the relevant milestones. Like when you have the EPAs from the Royal College and that PDF document that's encyclopedic, they have the settings, they have the patient population, but they also have the relevant milestones, right? And then that's what you guys looked into and had that Likert scale 1 to 5 rating scale, you know, to see what the changes were in the confidence in the specific milestones were. So I think that's you know, and the results, you know, show a substantial increase in confidence for resident trainees. You know, it looked like most of the time there was like a 20% increase in confidence, right? Like, you know, close to a 1 point increase for all the things you've measured. So I think that bodes well for simulation as a training modality for psychiatry residents. I think people are excited about it and they like it.
Yes, and I've emailed Hannah Solomon. Like I think we want to appeal to our general program director, Dr. Tan, to see how we could. Your needs assessment illustrates that there is an interest, but it needs, like you said, time is of the essence and limited. So we need to make sure it's captured as a mandatory, not mandatory, but a protected session that can allow residents to come together, bond, socialize in a playful, safe setting where they could potentially sort of avail themselves of a buffet of simulation experiences. And it sounds like we can make that happen for them. So maybe the next steps is to put your needs assessment data into action. And I think that's probably what we'll be doing coming, because you're going to have a protected half day, sorry, a full day, maybe a Wednesday going forward across the 5 years, the academic half day at least. So maybe that's something we can target.
Yeah.
For simulation work.
Did you say you emailed me about this?
Yes, I wanted you to share your slides because we're going to present to PRPC about this.
Oh, okay. Okay, great. Thank you.
Hi, can I just make a quick comment?
Yes, please, Pamela.
It's Pamela Kahn, and I'm suspecting, but maybe I'm not the only person on the call that is more of a lay person. I'm part of the Sick Kids Family Advisory Network and the Simulations Steering Committee member there. And thank you for being inclusive for family members and people even that are volunteering for advisory networks, for interested in participating to give their experience and advice. It's really phenomenal to see that some of the lived experience has been incorporated in this area in particular, because it is an area of interest within the Family Advisory Network significantly. And there, I know it can be intimidating, and you know, there can be issues around that, but there are a number of people like myself and others who are very interested in being able to contribute and find their way into expanding simulations and being able to affect outcomes in psychiatry. And I would just say that was an excellent overview for me to go back to some of my colleagues in the FAN with, so that I can even just share what's happening, that these things are, and how professionally and well presented and well scripted they are. So as to all of you, by way of feedback from families, as much as I can represent anybody else, thank you. Thank you for your efforts. It is appreciated. And I really appreciate being here and being allowed to sit in and listen, and as we find our way to getting more lived experience people in a meaningful way engaged. Thanks very much.
Thank you. Thanks for saying that, Pamela. I don't think we could end on a more positive note, a more gratifying note. So it's 4:59. I want to say a special thank you to our presenters today for making the time and for putting together, like Pamela said, an excellent, thoughtful presentation. And we've thankfully recorded it, so we'll be able to share it and disseminate it again. So I wish you all a wonderful evening. Get home safely if you have to, and thank you for your time.